Good evening, everybody. We have received a huge number of registrations for this event tonight. We will start the webinar in approximately 2 minutes in order to give all our participants an opportunity to join. In the meantime, please enjoy this short video. Thank you. I think we may have a slight technical hitch with the video. I guess it's going to start in a second. Please be patient. Thank you very much. Oh, it appears we have a slight technical hitch. I'm not quite sure if Catherine's going to start the video again. We'll have one more go and then we'll start the webinar. But in the meantime, it gives everybody plenty of opportunity to join because I can see the numbers rapidly increasing. Okay, it appears that the video doesn't seem to be playing. So good evening, everybody. My name is Steve Hussey, and I'm the General Manager for Women's Health Ultrasound EMEA. It is with very great pleasure that I welcome you to this evening's part one of a two-part Voluson Club webinar on a series with the topic of fetal heart or fetal cardiac abnormalities that will be presented by Professor Rabbi Chaoui. The topic of this evening's webinar is cardiac anomalies in the four-chamber view, from easy to challenging. Now, before I hand over to Professor Chaoui, I would like to remind you that if you have any specific questions regarding tonight's topic, please use the Q&A facility at the bottom of the webpage, and we will try to address as many of them as possible in a short session before we close a meeting later. Also, just to remind you that we will record this meeting tonight, and we'll make the video available on our Voluson Club EMEA page until November the 9th. So please now take the opportunity to join the Voluson Club. It has plenty of benefits for our customers, including tips and tricks, education, and product updates. So now I can see Rabbi is ready. It is with very great pleasure that I hand the Zoom meeting over to Rabbi. Thank you very much, Rabbi.
Thank you, Steve.
Recording in progress.
Thank you, Steve, for this kind invitation, and I hope my screen sharing will work. Yeah, it seems that it's working. And so, yes, ladies and gentlemen, I'm happy that we are almost 450 persons online, and then we'll start now with this topic. Some of you remember last year when we had seminar on the fetal brain, we were asking you kindly to give us a feedback, what you would like to hear as next. And many of you said we'd like to hear on the fetal heart. And my colleague, Dr. Haling, have shown you some normal cases and normal anatomy. And I will be focusing in this part one on the four-chamber view, and then the part two will be more in detail on the great vessels. And we'll discuss later on with Steve if there is a need for an additional webinar, or you can choose what we can cover, either the venous system or early scan or something similar. Why is the heart quite important? I'll change my slide here. You see here, this is the second slide, and it shows that the incidence of cardiac anomalies are roughly 1%. So every one of you, I'm sure, have seen more than one or two heart anomalies because you are, in a way, professional working on this field. Now, the numbers 10 can be also 8 to 1,000 or 12 to 1,000, but the number of a complex cardiac malformation is, let's say, standard in the whole world. It is 3 out of these 10 cases. So roughly speaking, 3 out of 1,000 live births have a complex cardiac malformation, which may need neonatal surgery or emergency or later on in life surgery. So this is how we define it. In other words, 3 out of 1,000 is 1 out of 300 cases. Now, the incidence in utero is by far higher because remember, if you are scanning a gestation or if you are scanning a fetus with multiple malformation, it will not end up in the statistics of pediatric cardiologists. And it has been shown that the neonatal and infant death, that heart anomalies are the leading cause of the birth defect associated death. This is why it is crucial and quite important to make the diagnosis antenatally and morbidity and mortality improve with the cardiac screening. Now, in the next 45 minutes or 1 hour, I will be discussing with you all these aspects. But let us start on our daily work. And I'm sure many of you have been working hard this day and hurrying at home or still at work watching this webinar. Now, this is here ideal life. The ideal world of prenatal diagnosis is making a nice images for the patient to calm them and having such a nice picture and asking the lady to give you a picture of the baby back after birth. And ideally, you will see it's nice and it is. They will tell you later on, do you know, doctor, it was exactly the picture you made prenatal. It has the same nose, the same mouth, and so on. But you know, like if you remember the Forrest Gump film, he said, Mama always said that life is like a box of chocolate. You never know what you're gonna get. And this is why in most cases you will have the nice letter that mother and baby are happy and thank you, doc, and so on. But 1 in 300 cases you may receive, if things go good, a picture of the child after surgery, because as I told you, 1 out of 300 cases have a cardiac anomaly, so a severe one. This is why you should be knowing, and ideally you can try to make the diagnosis properly prenatally to have, let's say, a thank letter instead of a letter of upset patient. So let's start with some numbers. You know, this is, I don't want to bother you with numbers during my talk because personally I will be focusing more on teaching today, but I want that at the end of the day that we have some numbers to know what we are speaking about. This is a good study published some years ago showing it's a meta-analysis. So different studies putting together some data from, as you see, some studies showing that if you make the diagnosis of critical congenital heart anomalies prenatally, the risk of death before and after cardiosurgery is reduced. And you see here, it is not everything not covering the one line shows that there is an improvement. So in other words, it does matter if you make a prenatal diagnosis. But how did all this started and developed? And when I wake up to ultrasound in the mid-80s, late 80s, there were 2 big persons working on this field. This is in France, Laurent Fermot, and in the UK, Lindsay Allen, who both retired in the meantime. And at that time, there were 2 different approaches. Both are pediatric cardiologists. And Lindsay Allen said the pediatric cardiologist should be examining a patient at high risk. That means we have to seek women at high risk and send them to the pediatric cardiologist. Laurent Fermot said, well, I think it works better if I go to the obstetrician and try to teach them to analyze the 4-chamber view. And in other words, this is the screening strategy we are doing today. So you have a high-risk patient, you send directly to a specialized center. But if you have a low-risk patient, you should focus on ultrasound screening. If there is any suspicion, you send to the specialized center. In other words, the detection at the specialized center, and you should know where you position yourself. Are you working on mainly on screening? Are you a referral place where patient will come? Depends mainly on ultrasound screening and not on high-risk patients, because let's say the majority of high-risk patients a priori risk, they have a very low yield, very low detection rate. So take a patient of having diabetes, or take a patient taking, let's say, some teratogenic drugs like anticonvulsive, anti-epileptic, and the risk of having cardiac anomaly is 1 out of 20. If a previous history of one child with a VST, it will be also 1 out of 20 cases, so 5%, not more. However, if you teach people doing good screening, and then you have a better success, especially that, as you know like me, that almost all patients, almost all cardiac anomalies are really at, they stem from patient at low risk, with some exceptions if you have an extra cardiac anomaly. And see now the results. The results in the UK showed that the detection, and around the year 2000, the detection rate of univentricular heart, like hypoplastic left heart or right heart, was 70% of the case, because they were focusing mainly on the four-chamber view, and transposition LCZ is miserable 3%. So this is why if you focus only on the four-chamber view, you miss the great vessels. The French, however, they have, let's say, the best screening, because they worked since mid-80s until the early 90s on the four-chamber view, and then realized, well, even obstetrician can learn to scan the heart, so let us move forward and improve the data. And it started teaching them how to scan the great vessel to detect the transposition. And you see the detection of transposition in the year 2000 was 72% versus 3% in the UK study. So in other words, the French approach is quite nice. What is not said here is that what is also the case in Germany and in France, that there the normal doctor is not scanning the patient. In general, they have some ultrasound specialists where the normal patient is referred to be scanned. So this makes sense to have specialists scanning the heart, and not to try to teach every obstetrician to treat endometriosis and menopause and then scan the four-chamber view in color Doppler and the great vessels. So this will not really work, honestly. This is why, if you are working in a setting, try to find people who really are interested in ultrasound and teach them. And this is a nice study by Eva Teklander from Trondheim, where sonographers and midwives are doing the study. And you see here that in the first part of the study, they published 2 studies. If they did not do any, let's say, targeted screening of the heart, 18% were seen with a cardiac anomaly. If, however, all nurses, midwives were taught to check every time the four-chamber view, they achieved a 26% detection rate, and when they included the outflow tract, they reached 41%. So I'm sure there is a potential, and these are all studies, but there is a potential to see more, especially if we now will include the 3-vessel trachea view. I'll show you next time. So in other words, and these are the data. I think if you take many studies, these are the data I can imagine could be put together, where we see that if you do not a specialized examination and no specialized team, you have less than 15% detection rate. If you focus on the four-chamber view, you have 15 to 40%. So I will be working with you to show you that even 60, 70% can be achieved if you know what to look at. And this is what I mean with basic, beginners, professionals, and expert. And the extended exam will achieve more. So in other words, this is what the data will show if you don't have a targeted screening. And for the first group, the first no target exam, look at the data from Germany. Here, this is a pediatric cardiology study. They analyzed 1 year, in the years 2006 to 2007, analyzing almost 700,000 births. We see that the heart anomalies were 7,000, which is 1%. 10 out of 1,000, and according to the parents' information, only 12% were detected prenatally. Now you say, how could you, Chaoui, have other data than in the country? Because let's say in almost all Germany, not all patients are referred on routine, while in Berlin we are really in luxurious situation that most doctors will prefer to send to one of the 40 specialists working in the city, and we have a really high detection rate. So the heart center in Berlin has, let's say, accidentally a case of a complex cardiac malformation not seen before both. But in general, most cases are well detected because patients are primarily referred to a center. And I hope this will work with you. Now, I want to finish the data with one study I like very much. This was a study published by the group in the Netherlands by Monique Haak and her group, by Van Nistelrooy. And what they did here, they analyzed why are cardiac anomalies being missed? And they have a group of sonographers who perform a wonderful job. And they went, the specialists, the doctors went to the data and find out, took out 90 heart anomalies, 50 half being detected, 45 and 45 not detected. And they analyzed what are the reasons to miss a cardiac anomaly. And they found out that the volume of the sonographer improved the quality. So that means the quality of ultrasound is mainly dependent on the quantity the one is doing. So if you scan 2 patients a day, or scan 10 patients a day, or 15 patients a day, it doesn't matter. Or if you scan 1 patient every second day, you will not have the experience of getting the proper plane and to analyze the image properly. So this is why to improve quality, you need to have a number of scans. And if you want to have a good diagnosis, you need the quality of the planes. So this is why you should train people to have a proper view, because the good image may provide the good diagnosis. And this is why the solution is, if you want to improve detection rate, you should improve the quality of scanning and the skills. And the second, even more interesting part of the study showed that in 30%, 1 out of 3 heart anomaly missed. It was clearly visible on the picture, but not recognized. So it is amazing that we think if we have a picture of an AV canal, everyone would see it, but this is not the case. This is why, and 20% were inevitable, but 30% means that 2 persons are scanning, one will present the picture but not recognized, but the other one will do. This is why the problem of perception ultrasound is really very important. And this is where now we come to our limit as a human beings, where one of these days, artificial intelligence may be improving, or let's say replacing some of our working. It will not replace the sonographer, but I can imagine the future when you are scanning that there is a background artificial intelligence telling you this could be abnormal, be careful, and then you wake up. It's like when you drive a car today, and you know from your, let's say, the modern system, they tell you that you are tired, or they know that there are cars around you, like in the Tesla car. So this is why this is some part. So in other words, today in my talk, I will be focusing on one part, how to improve the image quality, and second, on how to improve perception, because I will show you the abnormal cases. And the reason why I prepared the talk, and I was discussing with Steve Hussey, who presented me at the beginning, and I told him that we just finished the next edition of our book with Dr. Abu Hamad. We worked 3 years. We added some I don't know, dozens or hundreds of new images and 100 new schemes and so on. And we decided, like the previous edition, to write it like a cook, let's say, like a cooking recipe. So if you tell people, do it step by step, and you see here we were in a studio in the UK doing some pasta, and we said we should write the book like a cooking recipe. So this is why I will recommend you, and you see many pictures to have it. So let's start with the talk today. Today, I will be focusing on 5 aspects to improve cardiac screening. The first one is I will show you how to master the technique very shortly, because this is for me the prerequisite, the first condition, why and how to improve your image quality and to make the diagnosis. And the second is how to master the normal anatomy. Then I will show you examples on 4-chamber view easy detectables, where I say for the beginners, and 4-chamber view which are typical. So the one I think the professional will make the diagnosis. And the third group, you can call it challenging, you can call it expert level, and you will see some aspects of this. The first part on the master, the technique, I tell you that this is crucial, because what you are doing, you are scanning a fetus, and the main diagnosis will be achieved by the quality of the image. This is why you should use a good machine. I guess most of you are using the Volozone, so there is no excuse to say the image is bad, you have excellent transducer, the 2D and the 3D transducer, then you should learn how to adjust the presets. The system comes with good presets, but we have different tastes. And then you should learn how to optimize the 2D and the color image of your scanning and scan systematically from the upper abdomen to the great vessels. And last but not least, you should take your time while you are scanning. So don't do anything in a hurry. Take your time. And you say something, well, I don't have time. If you don't have time, you will miss something. So this is why it's like if you are driving, you cannot drive and do 3 things at the same time. So this is safety. And I know the machines are complicated, but honestly, if you ask me what is the secret of a good scan, I tell you is understanding the machine. And occasionally when you have a patient, the husband is, let's say, physicist or technician, he sometimes look at the machines that, oh my God, your machine is too complicated. Do you know all the buttons? I say, yes, of course I know all the buttons. I know even the subgroups of the buttons, because what I do is, when I have a new machine, I look at the buttons, I ask the engineers what they have done new, and I try to change this or that button. And he once said, you know, it likes a plane. He said, yeah, it's like, it looks like a cockpit. And this is why I put as a comparison a cockpit. Now imagine if you, now it's not allowed anymore, but in the past you look at inside the cockpit like this and you say, oh my God, you ask the pilot, do you know all the buttons? And he said, no, I don't know, but trust me. You will not trust him. This is why I ask you, please take your time and work on the machine, because this is the safety you are doing. So 2D optimization means this is a good image of the four-chamber view, but I prefer to have magnification because the size and the sector are too abnormal. So this is why magnify the image. And today in my talk, you'll see, I hope, only good images, and this one, the secret of this is that magnified and clear image. So this is why work on having a good picture. I show you here, for example, this is here with the new probe, with the RM7 probe, showing you the four-chamber view, and here this is the stomach, the four-chamber view with the three-vessel view with the bifurcation of the pulmonary artery and the aortic arch, where you see clearly what's going on. You see even here the thymus and the diaphragm and the aorta. So this is why please work on the picture, because the good image is the prerequisite of a precise diagnosis. Then keep in mind that the good image is like, as I'm showing you here, a magnifying glass, because you see details, and wipers. So this is why if you compare it to what we are doing, if you have a clear image, is like driving in the rain and you don't have wipers, so this is too dangerous. And you should also move the probe to get behind the shadow. So this is why if the fetus is not lying in a good position, especially in second trimester, you can go behind the bones. For example, this is the rib shadows here, 2 cases. Either in one case, you will scan between the ribs to see the heart because you have shadowing here, or you move the probe to get in front of the rib to get into the heart. The other point is what I will compare is color Doppler is your safety airbag. Believe me, remember this word, is your safety airbag, because without color Doppler, you may miss many things. Many years ago in the early 90s, we're supposing color Doppler is only helpful when you have a cardiac abnormality. Today, I tell you, if you do, let's say, a scan without color Doppler, it's like you're driving all the time without airbag. You are afraid because of an accident, you will die. So this is an example of excellent image quality with the radiant flow, and you see the 4-chamber view here and the 5-chamber view and the great vessels. And why I'm saying with the safety with the airbag, because the questions we will ask with the color Doppler are not today enough blood flow, direction, atypical shunts, and so on. The main questions are really where it is a kind of safety airbag. If you are doing in all patients in screening, you will find let's say accidental findings, which helps you in detecting the abnormality. Or if you have limited visualization or early gestation, there is no way to scan the heart without color Doppler. I take the number 2 of the list and show an example. So look at this one. What can you say in this case? You have an acoustic challenge, or we can call it also high BMI of the lady. There is zero information on the heart. By adding the color Doppler, you see it. I'll show you here an example. So look, you have this kind of fetus, you don't see anything. It's not a question of ribs. There is zero information. You see only heart action, heartbeat is positive, nothing more. Now, activate your color Doppler, and you see on the parallel view and the dual view that at least we have two chambers. There is no single ventricle, there is no dextrocardia, there is no large AV septal defect, there is no hypoplastic left heart syndrome. So almost all anomalies I will show you can be ruled out within few seconds. So this is why please use it on a routine, because you cannot use it on the day where you have an adipose patient like this one, because then you have to learn how to adjust the probe, how to augment the gain and so on. So this is the part which can be important. Now, the next point is we have, of course, guidelines, and you should do it systematically, but please try to do more than the guidelines are requiring. And so this is here kind of summary what we'll be doing, but today I thought we'll be maybe focusing on the 4-chamber view, and this is why be a little bit better than what the guidelines are requiring. There are 3 levels of detection. So this is why people ask me, oh, you know, the cardiac anomalies are so complicated. Come on, it's not the case, because you should distinguish. What I want from all of you, that if you are scanning a fetus and you say it's normal, it is definitely normal. There is then a second group where you are not sure, and you say it looks abnormal, it looks like an anomaly. And then you can refer the patient to a professional or to an expert where he can make the diagnosis. So this is quite the difference between screening, telling always the normality, and then getting into the suspicion of a cardiac anomaly and to the final diagnosis. So what I will discuss now with you is the 4-chamber viewology, which is the science of the 4-chamber view in this next half an hour or 40 minutes. So now you see here, this is the basic level of ultrasound is when people are counting the chambers. So they say 1, 2, 3, 4. I see the 4-chamber view, and they should move from the upper abdomen toward the heart to see that the heart is on the left side. But now the professional will do a little bit more, because he will analyze the situs, and he will analyze the details that the heart is on the left, the descending aorta is on the left. And let's go now to the details the professional should be checking. Putting the cardiac axis like this, 1/3 of the heart is on the right, 2/3 are on the left. The cardiac axis is pointing to the left with an angle of 45 degrees. Then looking carefully to the ventricles, you will identify as a professional that the LV, the left ventricle, forms the apex of the heart, while the RV is not forming it. The tricuspid valve is slightly lower than the mitral valve, and there is a trabeculation in the right ventricle. And the professional will have a look also to the septum, showing that the septum is intact, while the interatrial septum has here a kind of small opening, which is the foramen ovale with an interatrial communication being present prenatally. And that's it in general. So now the expert, however, will be also understanding what's going on in the region behind the heart. He will see that the shape of the left atrium is slightly abnormal, not abnormal, but said irregular, with the presence of the 2 pulmonary veins seen in the inferior one in the 4-chamber view. He will see that the aorta is almost touching the left atrium, because there is only the esophagus between, so the space here is quite small. And there is also on the right side of the vertebral body here, close to the aorta, the very, very, very tiny azygous vein. You don't see it at second trimester, but you see it in the 3rd trimester. So this is why this is the region behind the heart. And furthermore, the expert will understand also how to scan systematically the venous system from the upper abdomen toward the coronary sinus, the pulmonary veins, the azygous vein, and the brachycephalic vein. So you have quite different planes than the one we are using for the ventricles and so this is a kind of summary how I want you today at the end to be able to scan the heart. So if the baby is lying in good position, go ahead. Some people are doing their work in a stubborn way, so systematically from biometry, and then I don't know, the face and the brain and so on. What I would recommend you, if the baby is lying in a good position, the heart is quite challenging. Start with the heart, because if the baby is lying on the back, you have one sweep and you have the heart within really less than 1 minute. 1 minute 2D, 1 minute color Doppler, and then you have all the planes and all the anatomy you need. Now let's come to what is the basic. What is the basic, or let's say beginner ultrasound? The basic is, for me, focusing on obvious findings. So this is what I mean with detection rate of 15% or 20%. So even if you don't have any experience on ultrasound, this is the basic. You try to look at the heart and you see that there are a lot of rhabdomyoma, or you start to scan the heart this way, you see there is pericardial effusion and the heart is not contracting very well, a cardiomyopathy. This is detectable. The reasons here can be genetic, can be infectious, or can be, let's say, anemia and so on. Now, obvious finding in basic scan are large heart, typically in the so-called Epstein anomaly. In Epstein, what you see here is the tricuspid valve is not attaching a little bit lower, but really lower, leading to a dysplastic valve. And using color Doppler, as you see with the radiant flow here, there's a severe regurgitation explaining why the ventricle, the atrium is enlarged. So you see at this stage now, you should understand that even if you have missed the four-chamber view in the previous case, with color Doppler, you see that there is definitely an abnormal perfusion, which makes you wake up and realize, oh my God, yeah, this is true. Obvious findings also are when the left ventricle is enlarged. In rare cases of critical aortic stenosis, we see with the huge dilation of the left ventricle. Furthermore is when the four-chamber view, when we are counting the chambers, we see that there is one chamber missing. So you see here a single ventricle. We don't see the four-chamber view. We have one chamber here. We have one chamber here, one chamber here. So you see this is for the one believing that the four-chamber view analysis is counting the chambers, they will detect some of these. This is why you see that even in the let's say in the German study and the UK study, the univentricular heart was detected in 60% of the cases. But why not in 100%? Because these cases were the one where they were rather counting the chamber than understanding. Now I come to the second group, which is the largest one, the typical anomalies for the professional one. So it can be some typical anomalies seen like cardiomegaly and so on, but in general, it is the small ventricle on the right or on the left, the presence of a single ventricle or septal defect or arrhythmia. So let's see now the difference to the basic person. The professional is able to see even the presence of the four chamber, 1, 2, 3, 4, 1, 2, 3, 4, that there are here quite anomaly. In this left case, the apex of the heart is not formed by the left, but in the meantime, by the right ventricle. Here there is a very small right ventricle and hypoplastic right heart syndrome. Here the ventricles are there, 1, 2, 3, 4, but the left side in comparison to the right side is quite narrow, so there is a disproportion of the ventricles, and here there is a gap in the center of the heart. So why do I know this? Because I learned it. This is why what I'm saying, it's not obvious that anyone can see these anomalies. So this is why I can understand in the study from Holland, from the Netherlands, that some of these images maybe have found, but the examiner have not realized that this is an abnormality. So this is why this is how you should teach people not only to count the chamber, but to analyze the heart. And this is what we are doing in this meeting today. Now, the heart position can be abnormal, especially when the heart looks not on the left side. It can be either in the middle, in mesocardia, or shifted to the right in dextro position, or rotated to the right in dextroversion. So if you have a shifting to the right side, analyze always the position of the heart, but also the axis. The axis is pointing to the left. Here you should keep in mind, if I remove the abnormality after birth, the heart will return back to its position. So if you remove the pleural effusion, if you operate the diaphragmatic hernia, or if the lung lesion will shrink, the heart will return back. This is why it's only shifted to the right side. This is what you call dextro position. However, in these cases, the heart during embryological development has wrongly rotated and is pointing to the right side, and it is almost all cases associated with any abnormality. Sometimes the heart looks normal, but this is considered as an anomaly. And rarely, what we don't discuss a lot is when the heart axis is pointing more to the left, what is called levorotation. It's too much left because it's anyway on the left side, but a little bit more. So in these cases, you might have some severe anomalies. Often you may have conotruncal anomalies like tetralogy of Fallot or common arterial trunk, but also it can be associated with the right-sided aortic arc. So this is why the heart to the left, but it's more tricky to diagnose these conditions. So this is a patient who was referred to me because of a suspicious severe cardiac defect, but this was not the case. what the doctor, even a professional, did not recognize is that the stomach and the heart apex were on different sides. You have here the stomach on the left and the heart is pointing to the right, but the connection of the great vessels was normal and the baby was born without any problem. But you see here, this is the situs. This should be discovered by a professional, because when you are scanning, you should start with the abdomen, move to the thorax, and recognize that this abnormality is present. Now let's go to the most common conditions. These are the small left ventricle. The small left ventricle, we have two most common conditions. One is called hypoplastic left heart syndrome, and one is called aortic coarctation. People think if the ventricle is quite small, it is definitely hypoplastic left heart syndrome. But I want to show you for these very, very common anomalies, almost 7% in each of cardiac anomalies, what is the difference? So look at now the heart, and what you see here is the contractility of the left ventricle is very, very let's say limited. And the apex of the heart is not formed by the right ventricle, but by the left ventricle, but by the right ventricle. Adding color Doppler here, you see a non-filling, almost absent filling of the left ventricle. So for you to keep in mind, a hypoplastic left heart syndrome is not a true syndrome like genetic syndromes. It's called like this because it's a combination of findings. But what is important is to keep in mind the left ventricle is not working and will not be working after birth. So keep in mind, there is no function of the left ventricle in hypoplastic left heart syndrome. And in comparison, the aortic coarctation with an apparently small left ventricle, there is only a disproportion of the ventricles, but look at carefully. You have a normal pumping, normal contractions of the left ventricle. And by adding the color Doppler, you see here a nice filling of the ventricle. So the heart apex is still formed by the left ventricle. So you have a normal function working left ventricle, but the ventricle is rather, let's say, quite good working, but rather narrow compared to the right ventricle. Now let's compare both on grayscale, and you will agree with me that sometimes it's quite tricky to see is the apex really formed by the left ventricle? Is the contractility here on the right side normal in comparison to the left one? This is why compare now your safety airbag on color Doppler. Look at the color Doppler is so straightforward diagnosis. You see that there is no filling of the left ventricle and the filling of the left ventricle in the coarctation. So this is the first step. You add color and you have at least a direction of decision making. Now, how can we confirm the diagnosis in getting to the three-vessel view, three-vessel trachea view? Let's move to the next plane. Under normal conditions, you have an anterior flow in the pulmonary artery and the aorta. If you have a hypoplastic left heart syndrome, you have almost a reversal flow in the very tiny aorta. Sometimes you don't see it even on 2D. However, in coarctation, because you have a left ventricle with the filling, you have a patent aortic valve and you have an antegrade flow, but the aortic arc is narrow because of the coarctation. This is what we should expect to see. And if I remove this here, I remove the schemes, you will see on the pictures the normal aortic arc, the reverse flow in the aortic arc, the hypoplastic left heart syndrome, and the antegrade flow with the narrowing in comparison to the normal heart. So you have the suspicion diagnosis in the fourth-chamber view, and you can confirm it with the three-vessel view, but this will be discussed in the next meeting, I guess. Now, another group is when the right ventricle is small. There are two common conditions. On one hand, it is the entry to the ventricle is closed, which is the tricuspid atresia, or the outlet of the ventricle is closed, which is pulmonary atresia. So let us see here an example. You see here there is almost one chamber, the other one is small. But if you have at color, you see that the color will fill the right ventricle. That means the right ventricle should get blood, and the blood is coming via the VST. Or if we go to the other condition here, what you see here is a small right ventricle and a kind of bulging of the septum to the left side. You add color and you see an absent flow. So look at the middle image. I'm not sure that everyone will see this small, quite small chamber, because occasionally the right ventricle appears a little bit smaller than usual, and you don't know if it is because it is by definition small or it's big because it's abnormally small. By adding color, you see there is no flow. And then you wake up and say, oh my God, there is a problem because I'm missing filling of the right ventricle, and this could be hypoplastic right heart syndrome. Now, I've shown you some of these cases here, but look at the condition, what many people call single ventricle or univentricular connection. It is a spectrum, because I've shown you, it can be also cases with hypoplastic left heart syndrome with an absent ventricle, but the typical single ventricle is double inlet ventricle. So and this is here what I mean with this condition. So a typical single ventricle are 2 atria with 1 chamber. In general, you have an additional small rudimentary chamber on the side. And this is here how it looks like. On this picture, honestly, it looks like a tricuspid athesia with a VST. By adding color, you see that there is the flow from the right atrium into the common chamber. So 2 atria are draining into 1 ventricle. And this is what we call a double inlet ventricle. And this was double inlet to the left ventricle. Another example here. So in other words, I discussed with you many of these now abnormal, let's say, gross anomalies of the heart. Now let's come to a more difficult group to be detected, which are the one with the septal defects. In my talk today, I will not cover the atrial septal defect, but I will focus on the ventricular and the atrioventricular septal defect. So in the VSTs here, you see this is a heart of a fetus with trisomy 18. You see some polyhydramnios, you see the echogenic focus, and you see in the inlet part here a large VST, and this one here also one with a large VST in the inlet part, because it is showing the AV valves opening, and you see here the large VST which can be seen. But most anomalies we see in the fourth view are probably the small muscular VSTs. You don't see on 2D, rarely, but on color Doppler, especially if you are using this sensitive color Doppler, you see clearly that there is a shunting across the VST here. And look at it again. So in this, I tell the patient, if without color, I would not have seen it. This is why it's too smaller than 1 millimeter. Very rarely, and it is only, we took it for the book. You see it in these cases when it's quite larger than 2 millimeters. You may see it on 2D, but in general, you don't see. So it is an accidental color Doppler findings. With the clinical significance we can discuss later on is quite low, but you have when you see any VST or any cardiac anomaly, check for additional abnormalities. Now let's move to the more complex one, which is atrioventricular septal defect. Now you see in the AVSD, or AV canal or endocardial cushion defect, it's a combination of an inlet VST, an atrioseptal defect of the septum primum, and the valve, when it's closing, it looks like at the same level. So here the scheme showing you in the diastole how it looks like, and you see the large gap, but the gap is not always very large. This is why please do not focus as a professional on the gap, but focus also in systole on the linear insertion of the valve. That means the valve is in one plane. Why? Because instead of having a tricuspid and mitral valve, we have one common valve. And if you have only one valve, this valve is unlikely to be at different levels. So if you have a linear insertion, be careful. It could be the sign of an AV septal defect. And then you can add the color and see the filling of both ventricles with a connection across the interatrial septum. Now, and ventricular septum as well. Now, you may tell me, there are some cases I see on the normal fetus disc condition. Yes, I'm sure if you don't know how to adjust the machine, you can put a lot of gain and produce on each fetus such a picture. This is why my message to you, remember the airbag, be focusing on getting the perfect picture. If you have good presets you have done, then you can be safely using the color to show that there is a true mixing here. Otherwise, switch off the color, look at the valves. If you have an abnormality, then it is confirmed. We see here an example of color Doppler filling, and it looks like the letter H because the two arms here are connected with the middle, and this is here how it looks like in the scheme on the diastole on AV septal defect. Now, we have done the work of the professional, and now I come to the last group, asking why do experts, do you think, have higher detection rate? And let's say, I hope you will agree that I am one, I have some expertise on this field because I'm doing this job since more than 30 years. Do we have better equipment? Yes, on one hand, but honestly, the equipment many one are using, which is, let's say, 6 years old, was the best many years ago for us. So the machines today, even in normal offices and normal hospitals, they are better than the machine we're using 15 or 20 years ago. This is not an excuse. Better image quality, yes, because we are working hard on getting the excellent picture. This is why we are working always on getting the perfect picture, on adjusting the preset. Years of experience may play also a role, more case in center, but I think what is very important is to keep on reading and learning and teaching and listening to other talks and looking at case reports. This is why the knowledge is, because you are expanding always and knowing what is published and some cases. And when you go to meetings or listen online to meetings, you will learn every time. And I hope you will learn some cases today. And think out of the box. The major mistake you will do is you see something, and like Chaoui said, I know this is hypoplastic left heart syndrome, and you miss to doubt on your find. This is why doubt always on your diagnosis, and you may succeed. So I showed you before hypoplastic left heart syndrome with the apex not formed by the left by the right. But this here shows you that the expert should know the spectrum of the disease. The spectrum of the disease mean, in this case, we have hypoplastic left heart syndrome, but not as hypoplastic. There is an absent left ventricle, and this is a severe form of combined mitral atresia and aortic atresia. So, and how to confirm the diagnosis? Get to the 3-vessel trachea view, and what you see here is the reverse flow in the aorta. So exactly what you know from the hypoplastic left heart syndrome. This is one of the, let's say, the spectrum. This is why you should not call this condition single ventricle, because it's not a double inlet ventricle. It is a univentricular anatomy in an aplastic left heart syndrome. So the pattern and the spectrum of the disease. Here, look at this picture. If you look at this video, look at now on the left side. If you look at carefully on the left side, even we are 18-week gestation, even by magnifying the heart and looking carefully, you hardly are recognizing the septal defect here. But if you focus on the linear insertion on 2D, you see that there is the common valve shows as it is in one line, and when it's open, you see the gap. So the gap is not always so obvious, but on color Doppler, if you have good preset, it's the straightforward diagnosis. So again, 2 points to know the signs of the diseases, not only focusing on the large gap, but on the linear insertion, and properly using, you see the valves are closed, properly using the color Doppler to see here the filling. So this is why knowing the details and how to improving the scanning by adjusting the color Doppler. Now let's move to the spectrum of disease. We know cases with balanced AV canal, so it's not enough as an expert to make the diagnosis. You need to describe a little bit more. I see in AV canal, it's imbalanced, or you see in AVST, it is unbalanced with a small left ventricle in general associated with a coarctation, or you see an unbalanced AVST with a small right ventricle in general associated with an, let's say, right ventricular obstruction. So this is important not to make the diagnosis, but to make more prognostic aspect by describing what part within the spectrum of the diseases, and this can be done when you read more pediatric cardiology literature. Now look at this case here and think for a minute or for a second what's going on here. Is their heart normal or abnormal? If you go systematically, you say, if you are careful, you say the axis of the heart is more rotated to the left. You remember I showed you a picture with these, and the descending aorta is on the right. It should be on the left. So in this case, it is what we call a right-sided aortic arc. It can be, when we look at the great vessels, a simple aortic arc to the right side, but it can be also tetralogy or fallow with the right arc. It can be a common arterial trunk, but you don't see in this plane. So, and this can be seen in the four-chamber view. So the four-chamber view has a higher detection rate, provided you know subtle signs. And this is what I'm putting these in the challenging group or the expert group. Now let's go to the next one. I'm sorry. I showed you this case before. Remember the VST? And you were all trying to look at the VST, but very, very few of you noticed that behind the heart, we have two vessels. And this is typical of an aorta with the azygos continuity. So in other words, what I'm trying to show you that the expert or the challenging cases is you are, let's say, focusing on one anomaly and you stop thinking out of the box. You stop looking to the other details, please, in this part now, watch what's going on behind the heart. I showed you one aorta to the right. Now this case is what we call the azygos continuity in an interruption of the inferior vena cava. So inferior vena cava is absent in these fetuses, and the blood from the kidneys and from the pelvic region comes and drains into the azygos. The azygos become dilated, and you see it as side by side close to the aorta, as seen here, as seen here. But you will see it only if you are focusing on the region behind the heart and recognizing that instead of one, there are two enlarged vessels. And you have seen the video. I'm sure many of you have missed it. And now when I show you the video, you guys, oh my God, it's true. Yeah, he's right. We see here now two vessels because you are focusing on the VST. So this is why once you see an anomaly, don't stop thinking, go and do your systematic approach behind the heart, do a seat properly and so on. And this is present typically in left atrial isomerism, or what is called polysplenia syndrome. In these cases, they have often AV canal. So the beginner or the basic person would say, I see the heart is bradycardia. The professional will say, I recognize AV canal in combination with a white spot with the echogenic focus. It could be Down syndrome. And the professional says, no, it's not Down syndrome because bradycardia stems from the left atrial isomerism. And I see as a confirmation behind the heart the two vessels, and this typical of left atrial isomerism. And if you want a little bit more, you can focus on the shape of the atrial appendage. And this is a left atrial appendage bilateral. But this is another talk, another topic. Now, here also, if you are focusing on the posterior region, and you remember I told you about the veins, this is one of the most common vein anomalies. 1 out of 300 fetuses have this abnormality, which is the left superior vena cava, typically associated with a narrow left ventricle. And once you suspect a coarctation, you should seek for this condition as well. Now, what is wrong here? Look at this video and look at this color Doppler. What is wrong here? The only thing which is wrong in this video is that you did not magnify. So use the magnification and let us have a look when it's magnified. And what you see here, if you work systematically, you see that in front of the descending aorta, you have the left atrium. You see it on the connection of the lung veins, but the ventricle connected to the left atrium is the right ventricle because it has the trabeculation, it has the moderator band, and it is shortest. So the apex of the heart is formed by the ventricle on the right, which is the left ventricle. What we have here are normal atria, but inverted ventricle. And this is a typically incorrect transposition of the great vessels. Now, let's have a look here. And this is the same heart because it's magnified. And because I told you, you see now that there is something abnormal. So if you are a little bit expert, you will see that the apex of the heart is abnormal. The right ventricle is abnormal. Look at the valves. In general, I told you the tricuspid valve is lower than the mitral. Yes, because the tricuspid is now on the left side, is lower than one on the right side. You see here the different levels. Now, the problem sometimes why this can be missed on the fourth chamber view is because people, they will switch automatic color Doppler. And you see here, and color Doppler can cover it. You see you have on the left side a normal heart, tricuspid lower than the mitral valve. Here is the tricuspid on the left. The apex of the heart is formed by the left ventricle, which is on the right. You see the switched ventricles, the atria are the same. Not easy to detect on the fourth chamber view if you are not looking carefully. And imagine if you don't magnify, zero chance. Now, if you are adding color Doppler, you will not see it. And this is why I put the color Doppler in the previous one to disturb you. And you see here, this is clearly seen, but color Doppler, you don't see anything because you say, well, the feeling is nice and so on. Occasionally they may have VST, but may have nice fourth chamber view and you don't notice. The expert could tell you, of course, there is an abnormal color here because this is right ventricular anatomy and so on and so on. So let's continue now with another case. Is this case normal or abnormal? Look at all the systematic approach. I put this to have a break to drink a cup of water. Remember, Forrest Gump, this is normal heart. Why I'm showing you this? Because when you are scanning, you think all the time, is it normal or abnormal? This is why you should go your checklist. And I'm happy now that you went your checklist through and you wanted to find something because you are expecting to find something. I will put another case. And you know, this is life. Life is like a box of chocolate. You don't really know when the anomaly is coming. It can come in the evening at 6 o'clock when you want to leave home. It can come in the morning when you think you are not warm to start your examination. This is tricky. Ultrasound is really a hard job. Let's take another case. Is it normal or abnormal? Another one to have a break. This one is abnormal. Why is it abnormal? Look at now. So vertebra, this is the aorta, the right ventricle forming, it's typical, the apex of the heart is formed by the left ventricle. AV valves look okay, septum is okay. Look at the left atrium, look at the wall of the left atrium. Is the wall nice? Let's return back to show the other case. Look at here, you should see the two lung veins entering the posterior aspect of the heart, of the left atrium. And here you don't see it. Now you go a little bit lower, and this is what you see here. You see a confluent vein behind the heart. The space is larger, and this is anomalous pulmonary venous connection. Yeah, I know it's not nice from me, but you know, this is life. This is why in life there are no mistakes, there are only lessons. I hope every case you miss, it should be the case you say, I will try next time not to miss it. Don't be upset. You are in good society if you have missed such a case, because if you look at this study published some 9 years ago from different countries, 19 centers in UK, Ireland, and Sweden, they put together data of children of 424 children with abnormal lung vein drainage. Guess how many were diagnosed prenatally? Out of the 424 cases, 8 were diagnosed prenatally. So almost all are missed. This is why if you want to improve, we should teach people how to look at these structures. And this is why I'm happy that one of the colleagues from Japan, Dr. Kavatsu, find a nice approach to check for this condition. He said, simply look at the diameter of the aorta, descending aorta, and look at the space between the aorta and the left atrium, or the atrium, the first atrium in front. And the space should be smaller than the aortic diameter. If it's larger, and the post left atrium distance is larger than 1, then it is abnormal. So again, if you look at the case here, you see the diameter of the aorta, and the distance is larger than the aorta, so rate will be higher, than it is suspicious for this condition. Now, knowing this information, look at this fetus. This fetus had the stomach on the left side. No, it's not on the left side, it's more in the middle. The inferior vena cava and aorta are not on the normal position, because if you put a line here, the line shows that both are on the right side. This is called juxtaposition. This is typical for right aneurysm. Then you have a dextrocard. You have heart on the right side, you have the stomach on the left. And then, knowing the paper of Kavatsu, you see that the distance here is large. And you say, it should be an abnormal lung vein drainage. When I saw this case, I said, guys, it should be, but I don't see them. It was 19 weeks. And then what you do as an expert, you take a linear probe and you scan with a high resolution probe, or even vaginally. And then you see the two tiny vessels here behind the heart. And I will skip this one. It's too complicated now. I think I'm too late in the evening to make it even more complicated. Sorry. So, and then we take this case. I told you, before you use color Doppler, you should know what's going on 2D. The patient was referred because of tricuspid regurgitation and not knowing what is the reason. So they saw a color Doppler, and then they did not take the time to look at more. And by switching off the color Doppler and using high resolution, I saw this structure here. What is this? This is myxoma. Color Doppler is covering the myxoma. How do I know it's myxoma? Because I remember many years ago, I read a paper by Dario Palladini, who wrote that he reported on a myxoma, and it was a structure like this. I remembered, okay, if there is something moving between the atrium and the ventricle, it could be myxoma. So I took my time. I wrote, sent this video to Dario. I said, please, my friend, do you remember your case? Can you tell me it is a typical myxoma? I said, yes. And he was so kind. He sent me the video of his case of 2002. It was exactly the same. So having knowledge, having written, having read many things in the literature, we came to the diagnosis. And you see here with the linear probe, and you see the structure here, and even with the 3D, with the stick, you see the like a tumor moving in and out in the right atrium and right ventricle. You may think it is a clot. It looks like a clot, but it's typical for a myxoma. So I come to the end, my dear friends, and I hope I showed you the different steps on how to improve your four-chamber view screening. If you want to be very good in your scan, keep in mind you should master the technique. Remember the symbolic, the metaphors of the magnifying glass, of the wipers, of the airbag, color Dopplers or airbag. If you want to be good, you should know how to master the normal anatomy, not only looking to the 1, 2, 3, 4 chambers, but looking to the level of the valves, looking at the area behind the heart, looking on the lung veins connecting, looking at the moderator band, and so on. If you want to be good and you want to improve your basic level of the four chamber, you should try to be systematically examining the four chamber and not only counting them. If you are a professional and you want to improve into the expertise, you should know the pattern of the different cardiac anomalies and let's say read the details in a book and not making the diagnosis by the first sight. And if you think you are an expert, be careful, because life is like a box of chocolate. You never know what you can expect. And I showed you many images in my talk today, and this is a small group of these you can find in our book. And then at the end of the day, you will be not only receiving a picture like this one, but you receive also sometimes a nice picture from happy parents saying, thank you very much. And if you think what you are doing is quite good, I'm sure you are missing always something in your case. This is why keep on learning and look at what Albert Einstein said. His insanity, he said, is doing the same thing over and over again and expecting different results. So work on the nice picture, work on a good diagnosis, work on ideal position of the fetus. And Steve will tell you by the recent update of the Volozone series. I want to thank you at the end very much for your kind attention. And I'm really happy. If you have questions, I will be happy to answer them. Thank you very much. And we'll go then now to the question answer session.
Hi, Rabbi. Thank you very much indeed. And I'm sure actually most of us will be queuing up to buy your new book because your images are absolutely fantastic. I know we decided before to plan a 2-minute break in, but for the sake of time, I know it's gone past the hour now. We have 7 questions in. No need? Okay, excellent. We'll go straight into the Q&A session. There's a number of technical questions and a number of questions related to anatomy. So would you like me to read them out, or are you quite happy to read them out first? And then
no, you go ahead. Go ahead.
Okay, we'll take the first technical ones first. I think because you optimize your image so well, I think a few people are confused as to which probe you are using during the examination. So do you use a convex probe, or do you use a sector probe or a linear probe for your examinations of the fetal heart?
Let's say I've never used the sector probe. I don't even have a sector probe. It's a convex probe. And I'm using mainly the LM7 or the electronic probe, but also the 229 probe. In general, I have my standard probe during my work. And if I need more, I try to use let's say, a high resolution for some targeted questions. If I'm scanning before 20 weeks, if there is any doubt, I will take even a transvaginal probe. So let's say the aim is scan systematically with the normal probe, and then when you need more detail, go to higher. I'm not scanning each fetus with the highest resolution possible because this is not possible.
Okay, excellent. Thank you. Perhaps we can combine the next 2 questions together because they're based around color Doppler. One is, how do you optimize your color Doppler image once you start scanning? What are the first things you work on with your color Doppler image?
So what I do in my color Doppler image is let's say simply saying, I focus first on magnifying the image. I take the color preset, and out of the color preset, I take the box, make it smaller, and using let's say, and then move to get let's say high PRF and all these things later on. So it is let's say it's quite easy. I take the preset of the let's say of the color preset and then work on it until by augmenting. I'm checking if I have a video on this here somewhere. I have it somewhere. I forgot. Okay. So take the color Doppler preset and then improve it by playing with the PRF and with the filter.
Excellent. Do you use any specific PRF for VSDs or AVSDs? That was another question in the chat box.
Yeah, in general, when I suspect a VSD, I will reduce the level of the PRF in order to document if there is any filling. So, but or crossing the septum. But in general, I'm not doing a lot on these things. Yeah. So, okay. Steve, I will share again my screen to answer this question because I think this is an important part.
Of course.
So let's go here again. This is nice on a live. So this is here what I do. Select the heart preset and make the box small and magnify the picture. And then when you add the color box, I will take it, put it also smaller. And then I reduce the gain, not only the PRF, the gain first to have less color putting in. That means like minus 12 or minus 13. And then I will adjust the PRF and filter. So the trick is narrow 2D, narrow color Doppler, less gain, and then first play with the PRF. 3 steps, 1 minute, you are done. In general, when you have a good preset, you will save it as let's say, a good preset, and then you can make a minor modification on this.
That was an excellent example. It will help. Well, thank you very much. Super. I have another question here. I think we've seen this one before, actually, on a few presentations. It seems quite controversial, but if there's a pericardial effusion, when is it significant? Is there a measurement you make on the pericardial effusion?
This is a quite difficult question. It depends on gestational age. If you see it at 16 weeks, it probably remaining of some thick nuclear translucency. It had been associated with Down syndrome. And if the heart is normal looking, well, people say roughly it's 2 millimeter, let's say, size as a cutoff. If you have less than 2 millimeters, it's nothing, but you have more, check for anemia, check for cardiac anomalies, for volume overload. I will do a cerebral medial artery to see if there is any anemia. I will do, let's say, ductus venosus to see if there's a reversal flow somewhere. And I will focus on ruling out any cardiac anomaly.
Okay. There's a couple of questions on actually measuring the heart. I have one question about the thickness of the myocardium, but do you actually measure the heart, or is it purely a subjective classification from yourself?
Yeah, in general, I do not measure the heart on a routine basis unless there is a kind of, let's say, previous history of cardiomegaly or anything. So, and this is why I do not measure the heart. But if there is an abnormality, I will measure in order to allow, let's say, a kind of follow-up later on. So if you say the left ventricle is, for example, a dilated left ventricle, and you describe it, next time it can be not dilated, but you have the same size. So if it's only subjective on an abnormal condition, it's difficult to compare. Because patients may move to a hospital and they want to have a comparison of data, so you can use it, but not.
Okay, I think we'll just take 2 more questions. There is one question on echogenic foci and a question on golf balls, so they may be answered at the same time. It's the same, yes. Yeah. So do you have any advice about them? I think that was the question.
Well, in the meantime, I forget them. They do not exist anymore in the age of NIPT. But, you know, let's say they used to be a kind of slightly increased risk for let's say transmit 21, but also do not underestimate a high risk for cardiac anomaly. Sometimes there is a muscular VST. When I see echogenic focus, I play with the color to rule out any VST because it can be associated. And I seek if there is any additional sign for transmit 21, I will, let's say, cite it. Otherwise, I will not describe an echogenic focus anymore.
Okay, excellent. And the last question I think we'll take is about VSDs. When do you consider a VSD significant? What sort of size would you consider significant?
Well, this is a good question. Let's say I will not say the size of the VSD, but I will use, let's say, the position. The muscular VSD are rarely of any importance. They will close almost all, or even if you see it on 2D, it's maybe not important. The clinical value, however, of a VSD under the aorta is of clinical significance because it may be associated with abnormalities. Now, if I understood well, I heard that once cardiologists after birth, they say if the size of the VST is larger than the aortic valve, it is definitely going to be operated. So if you have VST smaller than the aortic valve, this is a sign it can be followed up, even the perimembranous one. So this is a rule of thumb. Roland Matern is asking when I'm using HD flow to rule out the VST. I use very often HD flow because it's more sensitive than the color Doppler. From a lateral view, I augment the balance to see the connection and the role of stick. It's more, I did not put it in my talk today because I did not want to show you that if you are not doing the stick, you are not expert. So, but automatically, when you have a machine with the stick and you are working on cardiac anomalies, it's so easy to do the stick. This is why I added one case where it was more obvious to be seen than, yeah, the 2 millimeter cardiac vision is used for all 8, no, for second trimester, Dr. Bayani. Will you accept only apical position? No, I have to accept occasionally other position, but it depends. If the patient is coming for a second opinion because of a cardiac anomaly, I want an apical position. But on a routine, apical or right lateral is enough. Okay. NIPT is in all echogenic focus. Yes, you can do it, but you know, NIPT in echogenic focus depends on maternal age. If you are 20 years old lady, come on, one case out of 1,000. No, look, if you have a 20 years old lady, I tell you a calculation. 1 out of 1,000 women will have Down syndrome. You have 5% will have echogenic focus. That means out of 1,000 ladies, you need at least 20,000 to have one case of echogenic focus. And you have 1 out of 1,000 of Down. So it's so rare, don't lose your time. But if someone cited echogenic focus and referred to you, you can say, if you want, do it. And many patients will have done it.
Excellent. Rabbi, I think we're almost out of time now. So I think
I'm sorry that I was running out of time, but it was fascinating.
I think it's fantastic. No, I think I've really enjoyed the engagement.
Thank you.
Really, and I want to thank you for your absolutely fascinating, insightful, and inspiring presentation. I'd like to thank our audience for their participation and their time investment into the webinar tonight. I'd also like to remind our audience that we have recorded this. It will be available on Volleysong Club until November the 9th. And that's when we will have our next session, our next webinar from Professor Rabbi Chaoui will be on November the 9th. Please look out for the social media messaging and through Volleysong Club as well. And please save the date. And we look forward to seeing you all on November the 9th. Thank you to everybody for helping organizing. Thank you, Professor Rabbi Chaoui, for your entertaining
very much.
presentation.
Good night and stay safe all. See you in November. Bye.
Bye-bye. Bye-bye.
Bye all. Bye. Oh, done. I was running all the time. Yeah.
Congratulations. It was brilliant. Thank you very much indeed.
Oh, thank you. Thanks. Okay.
Recording stopped.
Okay. We'll go out and